Okay.
Yeah.
It is our 6th meeting today, guys. It's October 27, 2023. So let's start our Google Slides presentation.
Hey y'all, hope you all are doing well. Friendly Zoom reminders, just use your first and last name for attendance purposes. Always keep yourself muted, and if you have a question, feel free to type it in the chat.
Hi, everyone. If you want to get reminded for upcoming meetings or any events, you can always text 81010 to, or you text that number and just text, type in at SMC PHAA to that number. And also you can scan our QR code and it'll give you like a link towards our Discord, our website, Instagram, Facebook. So you can always be up to date on like future events, meetings. We even throw reminders for our upcoming meetings. So sign up on our website or Discord or Instagram even.
Hello, we have some upcoming events. We have our open house, which is on the 24th. Come check us out. During our open house, we'll be out with our tables set up and everything. It will be very fun, so please check it out. We'll have some merchandise that you guys could pick up. And then we also have a Club Road meeting on the 31st for Halloween. So we're definitely going to be decorating and having our table set up. And it's going to be a competition. So we're totally like trying to aim to win. And then also for next Tuesday on the 24th as well, I will be hosting a meeting or an event based off of Kite Pharma and my internship experience, and a whole new opportunity for SMC students and life science students in biology that are interested in biotechnology. So come check that out too as well virtually. And then as for our student spotlight, welcome to our student spotlight. As part of the association, we value the experiences and achievements of all of our members and want to take the time to highlight any goals, participations, and internships or other organizations or challenges you've overcome. Keep an eye out for the PHPA Student Spotlight from your emails for a chance to be featured in our upcoming meeting. Spotlight students will be notified when chosen, and we will announce in our weekly emails, Instagram, and our website too as well.
All right, and I would like to introduce Adrianna Rockwell, Dr. Eric J. Keller, and Dr. Isabel Newton to our meeting today. You guys have the floor. Thank you, guys.
I'd just like to welcome Drs. Newton and Dr. Keller for donating their time today to come and share with us about medical ethics and informed consent. So we're very grateful to have you guys. Thank you.
Thanks for having us.
Of course.
Give me a minute
whenever you guys
to
are ready.
share the screen now.
Of course.
Okay, how is it looking to you guys? Does it look like you can see our screen there?
Looks great.
Cool. All right. So Eric, do you want to begin? Introduce yourself.
Sure. So my name's Eric Keller. I'm in my final year of postgraduate medical training at Stanford. So 6 years after medical school and graduate school in ethics, and going to be joining a private practice group in North Carolina. I founded the Applied Ethics Initiative, which is a national initiative to try and make ethics a little more appealing to procedural specialties, because it tends not to resonate very well with certain groups of physicians.
Great. And I'm Isabel Newton. I'm an interventional radiologist at the VA San Diego and UCSD. I'm a professor there. Interventional radiology is a specialty that focuses on minimally invasive image-guided procedures, which means we do a lot of things that you could do with surgery. Instead, we go through tiny pinholes in the skin, and our patients leave with a Band-Aid. So the reason why we have the Interventional Initiative is because we are passionate about the opportunities that these types of procedures offer patients, but there is a lack of access to these procedures. And one element of the lack of access is the lack of knowledge. So we're going to talk a little bit about that. We're going to talk about how today, when we talk to patients, how we make sure that they understand their options so they make the best healthcare decisions for themselves. These are our disclosures. Really, the most relevant one for this is the fact that both of us are board members for the Interventional Initiative, and what Eric said about the applied ethics and IR.
So our objectives, much like Isabel already introduced, is that we're going to try and understand the common barriers to good informed consent. I think it's something that is so essential to what we do in healthcare and kind of a social contract we have with patients. But punchline is that it would suggest we don't do it very well. And there's a lot of reasons why. So talking about that, and then talking about what are ideal consent practices in healthcare and what are the current things that we've been working on and others to try and make those practices better.
So we want to start with this image, and this may be something that you're not used to seeing, art in the context of talking about medicine. But if you've ever had the experience of being a patient, it is a disorienting experience. It can be one where you sometimes feel like the object of things being done to you. And this was actually painted by an artist named Andy Sargent. He called this painting Used, Abused Monster. And this is what this guy looks like in his garage studio painting. And I bring it up because he looks like many of the patients that come to the VA, many of the patients that come to my office. And it's a reminder that anybody who comes through the hospital, and you guys are not jaded yet, you're so early on and everything, but for us, we sometimes forget that these patients come with their own stories, their own challenges, their own levels of comprehension, their own priorities. And so we remind ourselves of this as we go through the process of talking to these patients. This patient was paralyzed at the age of 40.
And we also thought we'd start with this poem, and I'm just gonna read it out loud because I think it's worth saying, which is a poem about pain. I can feel myself slipping away, fading away, withdrawing from this life, just as my father did. When the pain you're in is so great that you can't think about or pay attention to anything but your own pain, the rest of the world and all other life don't matter. I think about my friends with dementia, cancer, arthritis, and how much more pain they're in than I am, but it does no good. Their pain is not mine, and therefore, no matter how magnanimous I might want to be, their pain is not as important to me as my own. And so what tends to happen in healthcare is a lot of us feel this tension constantly through a lot of things that we do, between focusing on the people that we're taking care of, that intimate connection that we have as co-human beings and trying to take care of these people, and then the fact that healthcare is a business. It needs business to run. And so you have almost this tension between the person-centered care, where the person is at the center of that focus, and the revenue, the business side of it. And funny enough, the scales look very similar. So we, when we talk about pain, you might have heard people ask, on a scale of 1 to 10, what your pain is. And you kind of have these little smiling and frowny face things. And it's actually very similar to a customer satisfaction survey too, of that, very poor to excellent satisfaction. So there's that tension between patient and consumer. And what ends up happening is that on the person-centered side, you have things like trying to do consent well, goals of care is trying to, figure out what people's end games is when there is no right answer, and then equal access compared to things like, the revenue that you're bringing in, the regulatory pressures that we have, the time pressures. And what ends up happening is that scale gets tipped, particularly when you have limited resources like time. And so consent is really an opportunity, which is what we were kind of saying in the introduction a little bit, is that's really the start of the relationship that you have with someone as a healthcare professional. And sometimes it doesn't get really viewed as that, but it really is kind of that unique opportunity we have to really start things off on the right foot and really make sure that we are providing excellent person-centered care.
We miss the opportunity to educate patients about IR and what we offer. And we know from our own research that 72% of the general public does not recognize that interventional radiology or IRs are physicians. or what the specialty does. And 65% of patients who come to the radiology waiting room have no idea what IR is. So if you guys did not know what I meant when I said IR, you're not alone. You're actually in the majority.
Yeah, and so I like to envision it like this as an ethicist, that essentially, the average patient, right, is an uninformed consumer. You're trying to close a knowledge gap and help them make a shared decision, make them have an informed decision about their care and take them through that. And you're trying to close this gap. And because a lot of people might not be familiar with certain specialties like interventional radiology, you have a larger gap to fill, but the same time constraints. And it's really trust that bridges that gap. A lot of times you can't take someone from knowing nothing about something to being an expert of it in that short amount of time. And it's really trust in you that bridges that gap, but you can't assume that trust. You need to give people the opportunity to close that gap as much as possible. And so, in ethics grad school, I had this law professor that would always start the year asking this rhetorical question and being like, what do you call physical exam in a bar without consent, which is assault and battery? Just saying the fact that, we don't make people write down on consent forms to do a physical exam or, take their history or things like that. It's a little less formal of consent process, but it's just saying that everything that we do in healthcare to another human being is within the confines of this idea of it's your life and your body. And that's really important and underlines everything that we do. And it has a lot of medical legal implications, which, I mean, maybe you all don't think about as much at your level, but actually miscommunication around consent and procedures is one of the leading causes of why people get sued in healthcare. And so the entire idea of consent when it comes to procedures is just trying to explain what are we trying to do? What are the risks and potential benefits of it? And then what are your other options? And trying to use language which isn't filled with jargon so people can actually understand it, trying to use that plain language and manage people's expectations. People come in with their own assumptions. A lot of people now, particularly my generation, your generation, right, has Googled it, looked everything up online. They already have kind of their own preconceived notion about what's going on. So you got to meet people where they live. And it's important to realize that when you're getting into those conversations. And doing so is really important. It's actually been shown to improve the way that people are able to get through the procedure in terms of their anxiety, pain, and then also their adherence afterwards, which is really important for a lot of the things that we do. So the first step, which you'll learn about more as you go through this and do this in practice, is the first question you have to ask is, are you talking to the right person? So obviously the most important person in the room is the patient, but not all patients have the ability to consent for themselves. And so there's two concepts, not to get into the weeds too much, but the two main concepts are capacity and competency, which capacity is a legal definition. So we are all assumed once you're at an age to provide consent that you are competent to make medical decisions. But certain people in certain situations get deemed incompetent to make medical decisions by a court. And that's more of a legal definition. Capacity is a little different, so that every healthcare professional is able to assess someone's capacity, and that capacity changes. So I always like to think about it as being able to answer when and for what. So for example, let's say tomorrow I get COVID and I get really, really sick and I'm delirious and I'm out of it. I don't probably have capacity to make a very complex medical decision for myself, and someone will have to do so on my behalf. But then I might get better a few days later. Just because I lacked capacity, yes, tomorrow doesn't mean that I'm going to lack capacity in 3 days. And sometimes what happens is people have certain stigmatized illnesses like schizophrenia or dementia. They get labeled as not having capacity permanently, and then people won't even talk to them. They'll go and talk to their family or something else like that without really assessing whether today, now for this decision, they can make that decision on their own. And then it gets a little bit more complicated than that. And I don't want to get too far into the weeds with all of this, but just that then you have to figure out who's the right person to talk to, which there is a legal definition to that. And then you want to make sure that that person is, speaking for that person, not themselves. So what tends to happen is that, let's say someone's near the end of life, let's say my mom was near the end of life and she's not able to make decisions for myself. Well, I don't want to lose my mom. And so I might agree to more aggressive treatment because I want her to hold on and fight and things like that, right? But that's not really me making the decision on her behalf. I'm making the decision for myself. And these are hard situations to parse out, but it takes the time and sensitivity and thoughtfulness to think about it.
So when we are in the hospital, the reality is as you go through the medical education training, you're learning a language, you're learning a process, you're learning how to diagnose patients, how to recognize constellations of diseases. And through this process, you become more and more numb to some of the really horrific things that we see. Very, very, very sick patients, like on this screen here, this picture of a patient hooked up to monitors and to everything else is a very common experience that we might have in the hospital. So when it comes time to ask a patient for their consent to do a procedure that all the doctors kind of in the back room have decided is the best way to go, it often looks like this. A physician with a clipboard kind of lording over the patient, presenting them with their options really fast using jargon, and the patient doesn't want to look dumb. They don't want to go against their doctors. They don't want to lose their trust or be labeled as a difficult patient, and so they will just sign. And they may not understand really what the risks and the benefits are, or what their alternatives are. And in some cases, all these things are not completely presented to the patient. So we know that not all patients are the same. And as I said, they have different situations, different comorbidities, meaning other illnesses that might make them susceptible, different challenges and different needs. But we also know we make these issues worse because of our own bias and on a personal scale, and because of bias on a societal scale, which can disadvantage certain patients. So these are ones, patients who are emergency or who are in the hospital because they're already very sick, those who don't speak English that well or who are not native culturally, those with low education or those of low socioeconomic class, those who lack insurance, minorities, women, those with disabilities, LGBTQ, the elderly, and those who get labeled difficult patients for whatever reason. For these patients and for others, the experience of being a patient can make them feel more like a subject, like a spectacle, something that is intruded upon, that's helpless or powerless. And that, I believe, is really beautifully depicted in this painting called The Presentation by Dana Schutz.
And so trying to connect with patients on that level and make that shared decision, there's a lot of things that go into that. I think you can kind of break it down into these four main spheres that are then surrounded by some other important points, which you're really trying to figure out what's that person's values, what are their goals, what's their end game. Not everyone's goals related to their care is the same. How well can they tolerate that procedure? How people's pain tolerance and what pain means to them is very different. And then what's their understanding, what's the disclosure of those risk benefits and alternatives, and all that is kind of encased in these other things we've been talking about, like access to care, costs, resources, and ethics.
I muted myself. Sometimes we have patients who, when presented with the permission to stop, will gladly take it, but others are not prepared to face the reality of the end of their life. And they need help understanding and accepting what is to come. And I think that's perfectly encapsulated in Pryor's plea from Angels in America. But still, bless me anyway. I want more life. I can't help myself. I do. I've lived through such terrible times. And there are people who live through so much worse, but you see them living anyway. When they're more spirit than body, more sores than skin, when they're burned and in agony, when flies lay eggs on the corner of their eyes of their children, they live. Death usually has to take life away. I don't know if it's just the animal. I don't know if it's not braver to die, but I recognize the habit, the addiction to being alive. We live past hope. If I can find hope anywhere, that's it. That's the best I can do. It's so much not enough, so inadequate, but bless me anyway. I want more life. And then who defines futility? This is Brian. Brian was in his late 20s when he was diagnosed with a very severe form of pancreatic cancer that went to his liver. This kind of cancer produced hormones that would make his blood sugar plummet and made it very difficult for him to be out of the hospital. There was a procedure that we provide in interventional radiology where we can shrink that tumor with little beads that are soaked in radiation that we give through the blood vessels that feed that tumor. And that procedure didn't save his life, but it gave him more life, months, so that he could meet his newborn daughter, who was born exactly 9 months after he was diagnosed, and he had so eagerly anticipated her arrival.
So stories like Brian is what really illustrates the power of these relationships and these conversations. And that's why actually the way that Isabel and I first started working together is that as I started medical training, so after I got out of medical school, I just realized how often that these conversations were being kind of taken for granted, where people were standing over people's beds and everything else like that. And it's not that people are trying to do a bad job or anything like that. It's just that, like we were saying, it's all the time constraints and everything else. And it made me wonder, is there a better way to do this? And is there a way that we could empower people with resources in healthcare to maybe be a little bit more thoughtful and have a little more robust conversations? And so that's how I got involved with this nonprofit that we've been talking about, the Interventional Initiative. And that's what led us to kind of make this curriculum called I Consent.
So I Consent is a mnemonic, and you guys, you're going to start learning that you're going to use a lot of mnemonics to memorize things that are the beginnings of this language called medicine that you are going to embark on. And we, once we're done, with our medical training, that learning doesn't end. And so in some ways, we have to relearn things that we have forgotten. And sometimes that is stuff that is going to seem very sort of obvious to you, but for us, we're so used to speaking in a certain way with jargon, we forget that those words are not common plain language words. And we, forget that not everybody has a detailed understanding of anatomy or of all the things that we offer. So I Consent is a reminder to physicians who are doing the consent conversation with their patients of how to do this in a way that will support compassionate consent. So the I is for introduce yourself and your role. The C, and actually the introduction is very important because a lot of times, patients are just sitting in their room and they don't know who all these people in white coats are. And half of those people might not even be people who are going to do the procedure. So introductions become very important. The C is clarify your patient's understanding of their disease and options. And that could be simply, hey, what's your understanding? You may be talking to the person who invented the procedure and you just don't know. Or you may be talking to someone who didn't finish elementary school and who needs more time and clearer descriptions in order to be able to comprehend it. And by the way, education does not equal health literacy. My mom has a PhD in languages, but her health literacy is still at the CDC's 6th to 8th grade average health literacy because of the way that we speak. O is an overview of their options, including the risks, benefits, and alternatives of the options that we are discussing as being the most viable ones for them and the others. And then N is where you stop and you say, hey, do you need any more information? And there's an additional stop because we as physicians don't know how to stop talking and let those patients fill the space with their questions. So stop and listen to their questions and concerns. And then E is for explain your answer. N is, do you need any more information? Notice this comes again. You keep asking. And then at the end, when they have had their questions or their curiosities satisfied, you test their understanding through teach back. And you can do this by saying, I know the minute you leave here, your family's going to ask you what we talked about, or you're going to, want to summarize in your head, or maybe you're going to think about this. I want to be sure that I said this in a way that you could understand. Can you explain it to me so we can be on the same page? When you're talking to someone, as I mentioned, be empathetic, be curious. Who is this that you're talking to? You know, are they somebody who is a specialist in this thing you're about to talk about? Is it somebody who's educated but not knowledgeable about this particular topic? What is it that they know already? I mean, that's why if you ask an open-ended question, you can find the answer to that. And then what is it that they want to know? I mean, not everybody wants to know all the little details. Some people are rather squeamish about it and say, look, doc, just tell me the basics so that I can make this decision and go on. What do they value? What's important to them? You know, we had a patient that we talked about at our meeting last that likes to go out and hunt. Well, if they hunt, you know, we don't want to put a port, which is something that could kind of get in the way of that gun, on the right side if they're a right-sided, you know, gun user. So you want to ask your patients, like, what is it that you value? What's important to you? And what matters to them that, you know, they might not even know what to ask about. So being open provides space for them to fill it with the things that are important to them. You know, after all, being a patient is a really hard thing to do. There's anxiety at every stage. You know, if you're talking simply about procedures, just the anticipation for procedure, not knowing what to expect, if you're going to be in pain, how you're going to respond, if it's going to help your problem. And then there is the fear or the reality of discomfort or pain during that procedure. For some patients, it may trigger PTSD. We have patients in the VA who are victims of sexual trauma. And, you know, they're helpless. You're doing things to them. And then afterwards, there's the anxiety of, is this thing going to work? How long am I going to feel this way? You know, how long until we get the results if we did a biopsy? What happens next?
So one way of conceptualizing it that really resonated with me is there's actually a lot of different theories of ethics, and one popular one is called narrative ethics. It was kind of started at Columbia, and the idea is that you can think about that all humans tend to think in terms of narrative. Even if you look at like a picture, you tend to put like a time course on there when you're describing it, if you describe a picture to someone. And so the idea is that you're meeting someone in the middle of their life, right? You're in the middle of a chapter. And sometimes what disease does is that we all kind of have our next few chapters written out in our head. We have our goals and plans in life. And sometimes when you get a new serious illness, it kind of rips out those next few pages and you're lost. And so part of the way that you can think about the ideal way of partnering with patients is becoming a co-narrator with them and helping them rewrite what those next chapters are going to be it 10 chapters or 1 chapter, and trying to empower them in that way. And then just realizing, much like Isabel's been saying, that you're only coming in at one part of that story. There's a whole rich story there. And so I always have this phrase that I say to patients, which again, like sometimes they'll say, well, you know, what do you think? And I'll share, you know, my opinion. I'm like, well, you know, honestly, I would do X, but you're the expert on you because only you know your whole story, right? So I can tell you what I would think, but ultimately you're the expert on you. And another important pro tip with this is body language. It's actually really powerful. So this, again, like we've been saying, a lot of this stuff might seem like common sense and silly, but it's amazing how much you lose it and don't do it. So that standing versus sitting thing has been shown to be immensely powerful. So even if you just take the time, it actually doesn't take any more time to sit and be at this person's same level, really helps empower that person to have to speak their mind more freely and to have a more robust conversation. And I think it's really just that there's such a power differential already, you know, be it that, you know, you're in a suit or you're in a white coat and you're standing over someone who's might be having the worst day of their life, taking the time to sit down and kind of humanize yourself, open up with body language, make eye contact, uncross your arms. It really matters a lot to make these conversations better without taking more time necessarily.
I think, you know, I mentioned before, but I think this cannot be over emphasized. We must stop talking and let patients fill that space. When a patient is able to speak their mind, they feel more heard, and to use active listening skills will enforce that. So those are to reflect back to them what they're saying. Let me get this, you know, right. Let me know if I got this right. I'm hearing you say this. You can even just simply repeat it, or words of confirmation. I hear you. I see this. I can tell that this is very important to you. And then get very comfortable with the silence and let them fill that silence, because we know that most patients need about 91 seconds to speak their mind. And we as physicians interrupt them after about 22 seconds. So it may feel like, oh, they, keep going on and on, because we're not patient people. And as interventional radiologists, we're probably the least patient. But sometimes the investment of time at that outset yields dividends throughout the entire patient-doctor relationship. I mentioned asking them about their understanding before you launch into your shtick. And it is a shtick. We have this speech that we've all memorized that we go, hi, I'm Dr. Newton, da, 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 pain, da, da, you just mention all the things that you're going to say. And it becomes this, this rote kind of delivery, and it's not really a conversation. The benefits of slowing down are, as we mentioned, you improve the comprehension initially. You invite questions, which allows you to tailor what you're doing to the patient's needs, which after all is one of the most amazing things about minimally invasive image-guided procedures. It's patient-centric medicine. It communicates that you're focused on the patient, that they are your priority. You're not trying to race out of the room to go do something else. And then the cool thing is it improves adherence to the plan afterwards, because the patient was part of making the plan to begin with. Many people feel this way. Oh, I'm too busy. I can't stop. I can't, even if the small investment at the outset could make things go much more smoothly later on. The other thing that we notice is that sometimes patients come to us and they are pissed off, and it can make for a very awkward interaction. And a lot of people will just sort of white knuckle it through it. But I would urge you, even with any situation, to lean into the tension, slow down, lead with compassion, name it gracefully. I can tell that we started this off on a bad foot, or I can tell that you're really, that you're upset. Then listen and ask them, what is this about? And then, try to get to the root of their irritation. You may not fix it. And in fact, just listening is more important than trying to be the fixer of things. And this is a problem that we have in IR, because we actually fix a lot of things. If it is warranted, you can apologize. And then when it's appropriate, you can normalize. You can say anybody would be upset in a situation like this. You want to respect health literacy, because as I mentioned, patients come to us and the average health literacy level is 6th to 8th grade. And that was something that we know from a lot of different data. And the CDC recommends that we speak at that level so that we can talk to most patients. The personal degree of health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So this not only includes understanding, but how do you find it? And how do you use it? And that's what we, and the Interventional Initiative, are so focused on. Unfortunately, a lack of health literacy is a critical problem for most of the public. Nearly 36% of U.S. adults have low health literacy, and only 33% of patients with educations beyond college have proficient health literacy. And those figures drop precipitously if you go into the single digits if you only had some college or less. And older patients and minorities, especially Hispanics, have even lower rates of health literacy.
Yeah, I mean, it really is a foreign language. And the way that I do it is that after I introduce myself, I always ask people this same kind of question, which is kind of like, oh, what's your understanding of what's been going on? Tell me what you already know. And it's nice because, one, it goes back to that slowing down to speed up thing we've been talking about, but it also lets you get a pulse on people's health literacy by their word choice and what they say. And so then you can just adjust your word choices accordingly, so you're not coming off condescending by talking under people, but also not talking over people, which is usually the more common problem with that. Because like we've been saying, that health literacy is different than intelligence. You can be multiple PhDs and you're not familiar with this language. Just like if you asked me about, if I went into a classroom with Dr. Newton's mom about linguistics, I don't know very much about linguistics. So my literacy of linguistics is pretty low, right? Because that's not what I study. We all have different expertise. And so it's just realizing that we take it for granted in healthcare, trying to avoid that jargon. It's harder than it looks, honestly. And I think it's because we talk to each other in this language all day that we just forget. Like, I'll say nephrostomy tube all day long, but remember that I bet if I took a poll of you, do any of you know what a nephrostomy tube is? One maybe? No, right? Like, if you ask a bunch of physicians, they wouldn't know what a nephrostomy tube is. And I'll tell you because the emergency department mixes it up all the time because we all have different specialties, right? So it's better to use a different term and normalize things for people. So it's just harder than it looks, so it's worth appreciating. And then the other part of it, which is the next slide, is numeracy. So the idea is that percentages don't resonate with people as much, it ends up. And this has actually been pretty well studied in the social sciences. So 1 in 100 means more to the average person than 1%. Or, you know, if I'm going to say like 2 in 5 people or something like that, right? That tends to resonate more with people. So it's being conscious about when we talk about like statistics and how often things happen. It's nice to use that, and then to use graphics, representations, drawings, things like that. And we'll talk about that a little bit more later. And again, I know we keep saying that it's really important, and the reason why is because if you do have a lower health literacy, you're more likely to have more emergency room visits, longer hospital stays, less likely to follow treatments afterwards, as we've been saying, then also even higher mortality rates, and it is very common.
So one way to connect with somebody and really have them understand something is, you know, there's that term, a picture's worth 1,000 words, is to use visuals. And we can do that by showing them their imaging, because, you know, after all, we're radiologists first before we're proceduralists. Show them their anatomy, show them normal parts and abnormal parts, use illustrations like the ones here. Draw pictures, and you can annotate images to personalize it for them so they can go home with something that is theirs. We have a website here, theii.org. You can see it. It has information about minimally invasive image guided procedures, and there's a lot of different patient decision aids and other resources that you can access. You can also use vivid language. So certain analogies can help patients understand what we're doing. For example, I will, instead of using the word thrombectomy, I would say a tiny vacuum cleaner inside of your blood vessel to suck out a blood clot. Instead of saying microwave ablation, I would say, you know, I have a wand that is like a microwave on a stick that will cook that tumor and kill it without surgery, and then it's going to heal and you leave with a Band-Aid. Instead of saying thrombolysis, I might say a soaker hose, which kind of lets this this medication that's almost like a meat tenderizer sort of slowly go into the blood clot and dissolve it over time. You know, you can also make comparisons that give context. So a lot of patients come in, you know, worried about the amount of radiation. You can say, well, this CT is about the same amount of radiation as you would get if you took a transatlantic flight, or this complication risk is about the same as that getting hit by lightning. And then, you know, giving examples like the breast clip that I'm going to leave is half the size of a staple, or we're going to stretch your fistula, which is a way that patients get dialysis when their kidneys fail. We're going to stretch it open kind of like yoga for your veins. And so if it feels like a stretch, it's because it is a stretch. And then that makes what might be interpreted as pain as something that's more constructive.
And so what we did, you know, we mentioned this term patient decision aids, and essentially what that is just any sort of standardized visual representation that goes over in patient-friendly language, talking about that numeracy and literacy, what the procedure is, its potential benefits, risks, and alternatives. It's actually been really well studied to significantly increase people's understanding and satisfaction. But it ends up that they're not really well done. So the ones that are well studied tend not to be widely adopted and used by clinicians. And then most practices have kind of their own home-baked versions of them, which tend not to be the greatest for a lot of different reasons. And so one of the things that we were trying to do was, for our specialty, try and make better patient decision aids. These handouts would be available online and then in printed forms that people could get before they talk to their physician about these procedures, that use that patient-friendly language. It was vetted by multiple interventional radiologists across practice types, and then also patient focus groups to make sure that we're really meeting that mark of resonating with people with these vivid visuals. And it ends up that we started with handouts. This is an example of one of the procedures that we do. We started with handouts because it ends up, I know that, again, like our generation, right? I mean, we're very digitalized, but a lot of the patients we take care of are older. And even people in my generation, I think there's something powerful. And this has also been studied in the social sciences, the holding something. So having something physical that you take home with you really matters to people. More than just having it on their phone still. So that's why we started there. It's available on the website that Dr. Newton mentioned, theii.org, which you can look at anytime. I use it actually all the time myself as well, but of course I'm biased. And then this is an example of a consent for breast biopsy. So we talked about, like, you know, we're starting in the radiology world, so we're kind of a subset of radiologists that tend to do these procedures through pinholes, but also regular radiologists. It's kind of a misconception that we all just look at pictures all day, but we actually do have a decent amount of patient interaction, particularly in subspecialties doing procedures such as breast biopsies are mainly done by diagnostic radiologists.
So as we come to a close, I want to, end with this image here, which is a very famous painting. You've probably seen it, called The Doctor. And this comes from a time when we were with patients more than we did to patients. And I would like to urge you, as you embark on this journey, you're at the very beginning, don't lose sight of the power of being with someone. We cannot always save them, but we can make their journey less lonely, less painful, and more intentional. So here's a reminder of I consent, and we would like to acknowledge, and I'll let actually Eric do the acknowledgements.
Yeah, we've had a lot of support with this just because it actually costs quite a bit of money to get these thoughtfully done, professionally illustrated by an illustrator, Juliet Percival, who's in England. And then also a lot of support just putting this together, doing the focus groups. We wanted to make sure that we reimburse people for their time. It was thoughtful about that. We applied for some grants through the University of California, and then also got some support through some societies, institutions like Stanford, the Ann O'Barr Trust, to make this possible for us.
And here are references if anybody needs them. Also, we have this last photo of Frida Kahlo painting after her injury in her bed. Just to remind you that a lot of patients suffer a lot of hardship, but they find the light, and it's you as a physician have an opportunity to help guide them there. With that, we'll take questions.
I'd like to ask a question, if possible.
I think there was a somebody raised their hand. I'm not able to see that. Oh, here we go. I finally was able to chat to come up.
Oh, I went. You can go first, Adriana. Okay.
Are you sure? Okay.
Yeah.
Okay. What is the one thing that you hope listeners will take away from what you shared with us today?
I can go if you want. I think we're going to sound like I'm beating a dead horse, but people really take it for granted. I think it's so ubiquitous in healthcare that I think a lot of physicians don't realize the opportunity that they can have by doing little things to make their consent conversations better. So a lot of this is more of just an extended pitch to physicians to think about these things and realizing that there are resources out there to make it better without taking more of their time, which is usually the main thing is like, oh, I don't have time to, sit down and listen to people, let them say those 90 seconds, but it really doesn't take that much more time and really does matter a lot.
Well, thank you guys for inviting us. We hope that this was of interest. There was a question, what can we do not to get too emotionally attached to our patient and their stories? unfortunately, that becomes kind of a natural thing that happens because you see a lot of tragedy. But I can tell you that it's not always possible, and there are patients who still haunt me.
Yeah, I will say that I a month ago came home and cried about a patient. I think that you'll hear different philosophies in healthcare between compartmentalizing it and trying to keep that barrier, and other people that do it. I don't think there's, I mean, to get closer to patients, I don't think there's a right or wrong answer there. It's something that you figure out for yourself. But I think that if you're too compartmentalized, it's hard to have that human connection. And I'm not embarrassed to say that I do that. I think that for me, it works. I think about people a lot, and I get connected to patients, and then that affects me when bad things happen to them, just like it would anyone that I would know.
I mean, that's kind of the other side of, you know, when you care about someone, you're going to care when they're hurting and when they die. And so it's a loss, you know, and we have to comfort each other sometimes because there are patients in interventional radiology that we follow with cancer for years. And so, you know, there's an end. And also we remind ourselves that death is not a failure. Death is how we're all going to end, right? And so coming to terms with that and doing that in a way that that, you know, each person is able to write their story, as Eric has said, can offer a great deal of comfort.
And I think we keep skipping over Elias over there. He's been nicely with his hand up.
I don't know how to. I mean, I think he can just speak, right?
Yeah.
I just had a quick question for both you, Dr. Keller and Newton. Where you were saying kind of the trust bridges the gap between kind of, you know, a more typical understanding and like a really thorough understanding of someone's procedures. How do you two, as like health professionals, maybe where it's a new patient you're not very familiar with, how do you tell you have that trust?
Well, I think when they sign it, it's kind of giving you permission, right? That you're saying, well, okay. But what ends up happening, I think, is that like you'll do this pitch, and one common critique that you might hear is like, well, when I talk to patients, they just say like, well, whatever you think, doc, right? But it ends up that a lot of patients that say that actually wish they would have known more. It's just that they didn't feel like they could understand it, and they were embarrassed to ask those questions. So what I mean is that it's a concept from the ethics world, is that we tend to say that in the ethics world that it's like trust that closes that gap, and assuming that trust is paternalistic, but often there's some degree of trust there. In terms of how you know, it's, you know, it's hard. It's like reading anyone else. I think that you assume that you have that trust when they sign that and, you know, go through with it, but it doesn't necessarily mean that they trust you explicitly for everything, you know.
All right. Well, thank you for the nice. I think Grace Williams. This will have to be our last question, but yes, Grace.
I was just wondering, for a patient like a minor who can't give consent, but who you wouldn't want to feel kind of excluded or not understand what's happening to them, how you would kind of balance that.
Oh, this is a great way to bridge into the term assent, which is essentially consent without the ability to legally consent for yourself, which applies both in the pediatrics world, but also for adults that lack capacity. And the idea is that, much like you're alluding to, the recommendation is that just because someone can't consent for themselves doesn't mean that they shouldn't be part of the conversation. They should still assent to the procedure. And it's pretty hard to justify doing something to someone when they can't assent to it when they're of age. So let's say that you have like a 14-year-old or something that can't legally consent for the procedure, but they don't want it. It's hard to justify sedating and tying down a 14-year-old screaming, saying that they don't want something just because they legally can't consent to it. So generally you want assent as well. So I'm glad that you brought that up. It's something that we harp about a lot in the ethics world.
Thank you.
Well, good luck to you all. It's a long journey. If you're passionate about it and you want to do it, it's totally worth it. If you're doing it for fame, money, or anything else, stop, turn around, go someplace else.
There's better ways.
Much better ways. All right, guys, take care. Bye.
Thank you guys for coming, and thank you guys for presenting.
Our pleasure.
Well,
Bye.
thanks for having us.
Thank you.
Thank you.
Thank you.
Thank you.
Members,
Thank you.
please make sure you do the attendance link before you log off.
Is it possible you could send the attendance link one more time, please?
Okay, let me,
Thank you.
okay. Okay, it's sent. Of course. Mm. You have a great day, everyone. Does anyone else have any questions? A general question?
Thank you,
Everyone.
everyone.
Bye, Grace.
Thank you.